if you would like CME credit, and a CME certificate will be issued to you at the beginning of January. You have until December 31st to complete the the assessment forms.
Hi, everyone, and welcome to another edition of the Vancouver Bone Squad lecture series. This week, we have the pleasure of having Dr. Kevin McGill, Associate Professor in MSK Radiology and also Biomedical Engineering at UCSF in San Francisco. He's the Director of MSK Intervention there and the Coordinator of MSK Ultrasound Biopsy Service. He's a consulting editor for Skeletal Radiology, has interest in research related to ultrasound and image-guided procedures. He's also the chair of multiple committees at the ISS and the SSR.
The more common injuries. So the ones we're going to review today are the lateral collateral ligaments, the syndesmosis, and the deltoid ligament. And so today we're going to discuss some of the mechanisms. So the primary mechanisms are inversion, which would injure the lateral ligaments, usually the ATFL and CFL, but eversion, which may damage the deltoid ligament, and then also a combination of internal rotation and external rotation. With being a internal rotation of the distal tibia and fibula, and then external rotation of the forefoot, which can cause a syndesmosis injury. So let's start with the lateral collateral ligament complex. So this consists of primarily three ligaments: the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. The primary job of this is to resist inversion. And so even though we have tendency to discuss this as one ligament, it actually is often anatomically multiple bundles, more than one bundle, from 1 to 3 bundles. In this particular study, 80% of the people had two bundles, and so that was actually the most common configuration. So it's important to remember that when evaluating that on imaging. And then same thing with the calcaneofibular ligament, where there's a lot of variability. In this case, the variability more has to do with the actual location. So it can be superficial or deep to the ATFL. Also, because ATFL comes in multiple bundles, it can actually attach to one bundle or the other. So it's important to, especially when we're going to look at some ultrasound images, so it's important to make sure you remember that may not exactly be in the same place as you expect it. Also, the angle between the ligaments can vary as well. So let's start with the anterior talofibular ligament. So this ligament is this ligament runs from the anterior aspect of the lateral malleolus to the lateral talus. Here it is right here on the MRI. The primary goal is to resist plantar flexion, and so as you see in ultrasound, when you need to stress this ligament in order to help visualize it, one thing you can do is plantar flex the ankle. Also, it happens to be the weakest ligament, and it's involved in 85% of sprains. So whenever someone says they twisted their ankle or tore their had inversion injury, this is the one that they expect to be torn. And so it can also be torn in different areas. So here we have on the left, we have a situation where it's torn more anteriorly than the middle. Then the A2 is showing where the had intersubstance tear, and the A3 is showing where it is torn posteriorly. So it's once again important that if you're looking for a tear, make sure you realize it can be torn in any of these locations. Also, the degree of tear can change. So it can be, here is a lower grade kind of injury, and so this is a type 1, which has subtle increased intersubstance signal. Then here we have type 2, which has some diffuse thickening, abnormal intersubstance signal, and may have some partial discontinuity. And so you can see that with the arrow there, the arrow shows some of the abnormal signal and thickening, but posterior, and then the arrowhead shows the partial discontinuity. And then we have type 3, which is just a complete ATFL disruption. And so now here we're showing all 3 of these different types of injuries together, and so you can see how it progresses from a very simple to more complex, more serious type injury. So here we have the anterior talofibular ligament on ultrasound, and so you can see on the top left we have the foot, And then we have the red box that's showing the orientation of the probe when you're doing ultrasound in order to identify the anterior talofibular ligament. And then we have the ultrasound image, which shows the ligament include. And so you can see, you can actually, this is a fairly normal ligament. You can see all the different fibers. You can see it go from one side to the other. They're all seem to be in order. And then we also have the motion of sort of plantar flexion that we were talking about in the bottom left corner. And so here we have we have a star. And so whenever I'm discussing ultrasound, I often I put a star somewhere on one of the somewhere on the image. And so what I do is to denote what I call like the North Star. And so the North Star is essentially, for me, is an area on the body where something you can see visually, also you can palpate. So an area of the body that you're going to be able to identify before you put the ultrasound probe on. And when you're able to identify that physically, and you know the anatomy and you know where something should be, that's going to make it a lot easier to do the ultrasound and to identify the right structures. And so when it comes to identifying North Star, you ought to have a North Star for each area of the body that you're really trying to do ultrasound on. So in this case, with the ankle, since we're really just looking at sort of the medial and ankle, medial and lateral sort of ligaments, it's also in the same similar area. We're going to use the lateral malleolus, or the distal fibula, as our North Star on the lateral side, and then just the medial malleolus as our North Star. And so I think this is when choosing a North Star, you always want to find something that's osseous, so something you can palpate very easily, something that's superficial. So when you put that probe on, you're going to see it immediately, and you're going to know it's bone, and you're going to know it's exactly this particular bone and this part of this bone that you're going to build that you're going to start with. And it also is consistent. You don't want to choose something that has a lot of anatomic variability from person to person. You want to make sure that it's that's pretty much the same thing. And so here's a sort of paper that kind of talked about the like how positioning for when you are looking at sort of the ATFL, CFL. And so here it's showing the position of the probe when you can use, but then also it's not only position of the probe is important, but also showing the position of the patient. And so here on in 1A, you can see the position of the patient. You can have them pressing against something or stepping on something, so that then they can kind of move their ankle or whatever body part you're talking about. They can kind of move it themselves without you having to press it. And then some cases it's helpful to just have their leg or a foot in this case hanging off of the table, so that they have freedom. So you can. So, it's also easier for you to move in order to do the different dynamic stress maneuvers that may be required in order to make diagnosis. So here's an example of your ATFL we're looking at. And so here we can see, looking at it, and I see sort of a little divot there. And so, however, this is just a static image. So I'm thinking that, well, maybe it could be, looks like there's some sort of tear. Not sure whether it's a full thickness, partial thickness type of tear, but it looks like there's some sort of defect. So then what I'm going to do is sort of plantar flex to stretch it out. And so as you can see, when it's in neutral, the ligament is lax, but then when you plantar flex, the ligament stretches out and becomes straight. And so now you can tell that it's just a sort of a partial tear. So there you can see it becoming straight, and that means that's sort of defect showing a partial tear. So here's another example of ATFL injury. And so again, we have, so we're seeing, now we definitely see parts of the ligament. However, it looks a little fuzzy, not seeing it too well. Here, I'm assuming it's probably a higher energy injury, but I don't like assuming. I'd like to, how can I confirm that this is the type, what type of injury? This is a partial and complete tear. And so here, once again, we're going to do the sort of plantar flexion. So here, what we're actually seeing those two parts of the ATFL are actually moving in opposite directions. So there's this paradox of motion. We see the fluid coming up through the ligament. So here's going to be a complete tear. Now, there's another part of this that can be helpful as well. And whenever you're looking at ultrasound, I try to identify tears of tendons, ligaments. I do the same thing that we do on MRI, which is look for movement of fluid. So in this case, we're seeing a lot of fluid moving sort of deep to the ligament, but then we actually even see fluid moving more superficial to the ligament. And so here's the images of the with and without plantar flexion. And so we're seeing more fluid kind of on the outside of the ligament, and that's concerning. And so now we're going to see it in sort of real time. So once we plantar flex now, what we see is what we saw before, which we see that paradoxical motion of those two parts of the ATFL, and then we see a lot of fluid coming beneath the ATFL. But then in addition to that, we see this other fluid sort of increasing outside of it. And so this is something that these are all different things that we see in order to make our case that this is a tear. And so ideally, you'd like to see all of them all the time. You don't get to, that's not how things work. A lot of times and so you have to know that all these can exist. And so if you do see a fluid collection that's more outside, but you don't necessarily see the ligament very well, you can have like a higher suspicion that there's a tear. And so here's a paper that kind of looked at how often the types of tears people have when they sort of injure their sort of lateral ligaments acutely. And so this is what we reviewed, and these were 110 athletes, and so about 47% of them only for their ATFL, 51% for ATFL and CFL, but only 2% for the ATFL, the CFL only. So tearing isolated CFL tear is fairly rare. And so most tears are generally going to be ATFL or ATFL NCFL. So here's a much bigger study, which was sort of observational cross-sectional study looking at athletes with chronic instability. And so this looked at over 900 athletes, and so this one found that they were similar that about half of the people had isolated ATFL tears, and about the other half had ATFL NCFL. However, this one also looked at the tibiofibular as well, and so found sort of 8% with ATFL and tibiofibular sort of injuries. And so once again, just like on the previous study, in this particular case, there were no cases that found like an isolated CFL injury. So now we move on to the calcaneofibular ligament. So the calcaneofibular ligament, it extends from the sort of anterior aspect of the lateral malleolus to the lateral calcaneus. So it's injured with with inversion, but also resists dorsiflexion. So usually when you injure this as well, you may expect that there's some dorsiflexion component of the injury. And so this is actually pretty common. Like I said, is somewhere a lot of different studies end up somewhere around 50%. Some even go up, as high as 75% that it's when included with the ATFL and 75% of ankle sprains. However, there is a sort of more recent study that showed it's really important to identify these injuries because it's specifically a CFL injury can be associated with progression of osteoarthritis. And so here we have the ankle showing the position of the probe. And just a reminder, this is where we have there is variability in this, variability in the location on the fibula where it attaches or where the origin is, but also whether, as I said before, whether it's superficial deep to the ATFL, relationship to the ATFL is variable as well. And so here we have an image of the CFL in neutral. And so the important thing about this is that you're going to see the peroneal sitting on top of it. And so at some point the peroneals are going to be like sort of 90 degrees to the CFL. And so therefore you can and so that's what you're kind of looking for in order to evaluate it. And if you don't actually see that at any point, then chances are your CFL is probably torn. And so this is it, CFL in neutral, and you can see it has a sort of lax configuration. And so then it's compared to this where you stress where there's dorsiflex, you can see it now, it lifts the peroneals up. And so this is what you're looking for to confirm that's intact. And so here is another and this is part of that same paper from before showing the ATFL and CFL, how to sort of some of the tools you can use to identify it on ultrasound. And so here's showing the positioning of the transducer. In this case, they think it's prefer to put it, just hang the ankle over the examination table. And so this is what, since it's in this case, since the ankle's not very much dorsiflex, this is what you'd kind of expect to see, a lax CFL. And so just like with the ATFL, it can be torn at different locations. And so they can be classified that way as well, as far as being torn at the sort of anterior sort of intrasubstance or the sort of more posterior aspects. So here we have an example of the CFL in which you can see the peroneus longus and brevis sitting on top of it, but then also you can see the CFL, and you can see the different strands in the CFL. It's lifting it up. So you can say this is intact. And so here it's more neutral, and you can see there's like more laxity to it right there. And then here it's more stressed, and so it's a little bit straighter. It doesn't have to be like, it doesn't have to become 100% super straight. It just needs to be, you show that it actually lifts up the peroneals and straightens when you do dorsiflexion. And so that'll help you show that it can't, or it's not there's no complete tear if that does happen. And so there it is, sort of straightened. Now this sometimes is a little not easier said than done, because you have to, when you're doing this, same thing with ATFL, especially if it's intact, you have to make sure you keep an eye on it as it's being dorsiflexed or plantarflex in case of ATFL. But here's sort of a image that can show that it is kind of lifting the peroneals up, and so therefore this patient has a little bit of fluid around the peroneals, so they had some peroneals, some mild tenosynovitis, and so the question is, well, so the patient already had sort of pain in that area, and so we can say for sure they don't have a full thickness tear of the CFL. Now here's another case where we're looking at CFL, and we're looking at just a static image. What we're seeing is an area of hypoelasticity in the CFL itself. And so the question is, is this, are we going to call this a full thickness tear? Not. And so with me, I always make sure I get flips. I always get motion, whatever ligament, tendon I'm trying to evaluate. I always get that as well. I never rely on just still images. And so here, now this we still see that in the middle of it, we do see that area of like hypoelasticity going through the tendon, and the tendon does look for part of it does look somewhat thick. But as you can see, when you do that dorsiflexion, part of it does actually straighten out, and so it's once again we know it's not a complete tear. So this is looks like a partial tear. So now we move on to the posterior talofibular ligament. So the posterior talofibular, like I said, we've said before, the anterior talofibular ligament is the weakest ligament, and so it's involved in many sprains. This is the opposite. It's not very weak, and it's not involved. It's not involved in very many sprains. And so the posterior talofibular ligament extends from the posterior medial aspect of the lateral malleolus to the sort of lateral aspect of the posterior talar process. And so this one is much stronger than the others. And so this is essentially the house made of bricks. So it's going to be the last one to go. It's involved in, there's some study that showed it was involved in less than 10% of ankle sprains. There's another, I believe, smaller study that also showed it was about 11%, but somewhere in general, somewhere around there. It's really only in very kind of high energy type injury. So in question is, well, what kind of injury? Actually, before we get to that, here's an image of the posterior tibiofibular ligament. And so as you can see, you're going to go a little bit posterior to the peroneals when you're looking for this. So you're going to, it helps to actually see the peroneals in the image. And this, looks pretty good. It's actually pretty common for it to look very good. Even people who have actually injured other parts of their ankle. You can see the different fibers. It's fairly smooth. They don't see any sort of defects there. And so here's MRI showing a posterior tibiofibular ligament and anterior tibiofibular ligament. And so they said the question is, here's what kind of injury can cause it, what kind of injury to have. It's a pretty severe one. So in this case, would be analogous to having sort of tornado knock down your brick house. So here we have and so really it's only if you have some sort of ankle dislocation, are you going to injure that? And when you do injure it, the other houses that would have are most likely already been torn. So especially the anterior tibiofibular ligament. However, in this case, this patient did have ankle dislocation toward posterior tibiofibular ligament, the deltoid ligament, and probably a lot of others. But this is these are the type of injuries that generally where you see this tear. And so now we're going to review the sort of syndesmotic ligament complex. So one of the important things to take from this lecture is really that we often talk about ligaments as one thing, but it's really they're really a combination of actual ligaments. And so the same is true for this. And so syndesmosis it consists of 4 different ligaments. So the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, the inferior transverse tibiofibular ligament, and the inferior interosseous ligament. So the important thing about these injuries to the syndesmosis is that the one that's going to be injured the most is going to be the anterior inferior tibiofibular ligament, and it is oblique. And so make sure it's important to note that regardless of whether you're trying to evaluate this on ultrasound or MRI, it is definitely important to remember that it's not going to be definitely on MRI that it's not actually in the plane, most likely not in the plane of the images unless you specifically change the orientation in order to make it in the plane. And so it's the same thing with ultrasound. When you're scanning to find this, make sure you remember that it is oblique, so that you adjust your transducer accordingly. And so here's a study, here's a paper looking at different MRI techniques for the ankle. And so here we can see an arrow looking at the anterior inferior tibiofibular ligament. And so here it appears discontinuous, but as anyone who's read a lot of sort of ankle MRIs can tell you, it may not be. So here what they did, they just changed the angle of the sort of acquisition, and now we can actually see the full anterior inferior tibiofibular ligament, and looks very normal and intact. And so here's another paper that's something similar. Once again, just looking at the, and I think this is something that's useful if you have a specific suspicion for a certain ligament. One of the difficulties of this is that obviously you can't adjust it for every ligament, but you can, but if you have a specific concern for a certain ligament, then you can either get special oblique sequences in order to see these ligaments more clearly. Okay, so here's an example of the sort of anterior inferior tibiofibular ligament, and there's then we have the image in the top left showing the orientation of the probe. And so once again, just like with the anterior tibiofibular ligament, the other ligaments, it generally is going to, you're going to make sure that you see the fibers clearly, make sure you see it going from one side to the other. And that same thing with ATFL, you want to make sure you find your North Star. With the anterior tibiofibular ligaments, a little bit easier. As long as you pay attention to the orientation, it's generally pretty easy to identify this one. So this is, as I said before, the AITFL is the most common sort of injury that you're going to see, and this is they refer to it talking about a sort of high ankle sprain. So that usually tears first, and this is very common, a relatively common ankle injury for athletes. Remember, it's sort of the internal rotation of the tibia and fibula, but then with external rotation of the externalization of the forefoot, and so that's something that's pretty common position in sort of basketball and in like football, if people find themselves in. And so then the thing you're looking for, remember I said with same thing ultrasound and MRI. One of the things to remember with ultrasound and MRI when you're learning is that it's all the same. The anatomy of ultrasound is the same as it was for MRI. So if you're following fluid and seeing a fluid, in order to identify a defect in a tendon or ligament or whatever structure, the same fluid that you're going to identify going from one compartment to the other on ultrasound or on MRI is going to be the same thing you're going to look for the same thing on MRI and for ultrasound. And so remember we said it was 20% of ankle injuries in athletes. However, it's only overall about 5% of ankle injuries. As I said before, it's really mainly seen with sort of high energy activities. And so there's studies showing that sort of between 46 and 5% of syndesmosis injuries occurred during what they consider to be a high energy injury. And so one of the things you're going to see with these high energy injuries are this widening of the syndesmosis. And then also this patient injured their ankle probably a long time ago. Obviously you can see by all the general changes in the tibiofibular, the tibio-talar joint, but also here you can see the ossification in the region of the syndesmosis, suggesting this is a chronic injury. And so when it comes to figuring out dynamic maneuvers, that's another thing that make sure you want to do for ultrasound. You want to make sure you get your static image, then you want to make sure you get a clip. But then also, what are you doing when you're doing the clip? You're doing some dynamic maneuver. In some cases, it's just something that you just need to do with ultrasound to help you see things better. In some cases, what you're doing is just repeating a physical exam test that like the orthopods or the physical therapists or the sports med will do normally, but then you're doing it while looking at a certain structure on an ultrasound. And so here it's called a squeeze test. And so where you kind of squeeze the fibula and the tibia together. And then these are two tests that people commonly do for when suspecting a high ankle sprain. So another one is this external rotation test. You're sort of holding tibia with one hand, and then you're sort of external rotating the forefoot with the other. And so what you'll see, the one thing that you want to notice about both of those tests is that they require two hands. And so if you're doing ultrasound, if you're doing it by yourself, then it becomes a little bit difficult to do it well. Technically, you could do the squeeze test with just one hand. However, if you're working, that's maybe fine for sort of smaller people. If you have sort of larger people, especially if you're working with sort of bigger athletes, it's kind of much harder to do it with just one hand. So one of the things you can do is one of these sort of dynamic maneuvers where it's similar. Essentially, it's the external rotation test, but in this case, you're using the patient's putting their foot against the against the bed in order to brace so that you can do this external rotation. And so while you're imaging with ultrasound, what you're going to do is you're going to expect to see an increase in the sort of diastasis with dorsiflexion and sort of eversion, but then a decrease in diastasis with inversion. And so this test, at least in this study, found it to be 100% sensitive and specific. Actually, and oddly enough, there's another paper that was not doing the exact same test, but did also find the ultrasound testing for this syndesmotic injury using dynamic maneuvers to be 100% sensitive and specific. And so here is an example where we're not seeing, we don't necessarily see the ligament very well, even though we were trying to get the right angle. What we do see is we see some sort of like hypoechoic area that's going sort of from anterior to posterior. And so anything you see there is going to be sort of suggestive of some sort of ligament injury, because instead of seeing that, you should see the ligament. And so here, when you scroll through, this is, you don't really see the ligament, but you do see just some area that's kind of hypoechoic. And so here's probably a better case that shows the looking at syndesmosis again. Another thing I want to point out is this: oftentimes you can have this little ossific fragment that's kind of anterior there, and so that's something you can see that might suggest there's injury. So it's nothing you can see even without the dynamic maneuvers that you're going to be a little suspicious for an injury if you see that. And then also you once again see that instead of seeing the ligament like we did in the first image, that now once again we're just seeing some hypoechoic stuff going there in between the joint. And so now, and then once you do the squeeze, we're actually seeing it go in and out. So this is once again, this is where the ligament should be. So here we're going to say this patient has a prior injury to the AITFL. So here's another example. So once again, here's probably a little newer example. The other ones might have been sort of more chronic. This one, once again, we have that ossific fragment with shadowing that you see anteriorly. That is pretty common when you have these type of injuries. But and so now it's saying it's a little fresher because we are a little newer because now we see that fragment. We also see a lot of kind of edema as we scroll through and a little bit of fluid. But the thing that's really going to clinch it, and so once again, with like I said, with the looking at tendon injuries, looking at tendon ligament injuries, is really seeing fluid going from one area to the other. So that's what we're going to see here. And so once again, we're seeing this fluid that's coming out of the tibiofibular space and suddenly filling that area. And just like we saw with the sort of ATF, or similar with the ATFL, once again, once you see fluid coming from one place to the other, that's gonna help clinch your diagnosis. Okay. And so sort of last but not least, we're going to now discuss the deltoid ligament. So just like some of the other ligaments, it's on the medial ankle. It just like some of the other ligaments, it's complex. It's probably a little more complex than the other ligaments. And so here's it serves as a medial stabilizer. So it's pretty rare to have this, just a single big deltoid injury, isolated deltoid injury. it consists of multiple sort of superficial and deep components, which we'll get into soon. And so even when you think there might be an isolated injury, it's sometimes what you can have is what you call a Mason-Rube fracture, where the injury sort of propagates, up through the syndesmosis and then ends up creating a fracture of the fibula. And so there you'll see, when you see that widening of you'll see the widening of the mortis on the medial side, and then also a fracture of the tibia. And so once again, this is kind of a busy image, but here the area that we're really focusing on are the medial deltoid, which here they're just showing sort of 4 of the ligaments, but it actually can have up to 6. And so the deltoid ligament itself is sort of fan shaped. Fan shape has interverse fat, and it has the components of it. The deep part are stronger than the superficial part. So here are the 4 components that you might see in the superficial aspect. So I mean, this is not 100% consistent, like in all patients. There's, I think in some cases there've been papers that said that they've only, like the tibionavicular, for example, might only be in like 55% of the population. And then also the tibial spring is not actually really a true ligament, but it kind of goes from the tibia to the spring ligament. And so the so there are the 4 different ligaments. And so this is a paper that kind of looked at the different ligaments to kind of put them in the superficial and deep, and kind of showed you where to kind of help you to decide where to look to identify them. And so which one should be sort of superficial to the other. And so here we have the sort of the deep ligaments, which are the anterior tibiotalar, posterior tibiotalar. So these are actually the more important ones, because these are the ones that really are stronger, are the strongest ones, and these are the ones that are harder to injure. And so here we have the sort of, and these things on ultrasound, if they're there, technically you can actually sort of separate them out and identify the different ligaments themselves. So here's the, there's the anterior tibiotalar ligament there. Here's the posterior sort of tibiotalar ligament. So here are the tibionavicular ligament. And so when, things about ultrasound that, you have unlimited scanning planes. So remember, you can actually, so even with MRI, where you have to kind of think ahead and try to identify a certain scanning plane or get some sort of 3D images. Now with the much more advanced sort of MRI images, it might be more easier to get the images in the different planes. However, with ultrasound, it's very easy. And so you're looking for the tibionavicular ligament, you can just find that ligament that does go from the tibia to the navicular. Then here's the tibiocalcaneal ligament. And then here, once again, here's the posterior tibiotalar ligament. This is one of the ligaments that's important. It's more important because it's the deep part of it. And here's a paper that kind of showed a tear of that ligament. And you can see the intact tibiocalcaneal ligament superior to it as well. So yeah, so today we kind of went over the common ankle injuries, common sort of ligamentous injuries. So view the lateral ankle ligaments, the syndesmosis, and the deltoid ligament. And so these are very common. Here's a few different injuries that ankle injury people have had. And so here's this more classic kind of sort of how you get ankle sprain. We have that internal rotation of the tibia, fib, and that external rotation of the forefoot. Very common in football, or American football, sorry. And so for conclusion, so we said we were going to review the normal appearance of the ankle ligaments, and I put normal in quotation marks because it's not always normal. Normal's not always normal. There's a lot of anatomic variation. So even if it's normal, it may not look the same. So so remember, especially with like ATFL, we have two bundles. With the in CFL has a difference in where it starts, and just like the deltoid ligament, which we just mentioned, some of those ligaments that we mentioned are not really seen in everyone. So it's really really more focusing on the deep ones, so the deep sort of anterior posterior tibiotalar ligaments. And also we went over some common injury patterns, sort of inversion, eversion, sort of external internal rotation. And so we know, once the patient has said, how they sprained their ankle, then we can focus on then looking at specific ankles, that specific side of the ankle. That's one of the things that we try to do here is instead of just, when it comes to ultrasound, instead of just doing, ankle exam where we look at everything, really try to coordinate with our referring physicians and make sure they send it, when they do send the patient, they've done the exam themselves, and they have very strong suspicion of an injury in a certain area. And those are generally the areas that we're going to look at, and then do our own testing in order to confirm whether or not that is really the area that's injured. And then also we identified, we talked about how to identify different ankle ligament injuries, and especially dynamic maneuvers. Nothing that we do a lot, which you didn't talk about specifically, but is somewhat understood, is that we do try to look at the contralateral side. Also make sure you always look at still images, look at clips, have some sort of motion involved there, but then also even specific dynamic maneuvers that are designed to elicit to elicit whatever the problem is. And then also look at the contralateral side, especially not every anatomic variant is bilateral, but it can't help if if something is confusing on one side. Also varying the MRI imaging planes, that's another thing we can do that will help us see any of these ligaments a lot more clear. And that's it. And then of course I want to if you want to know more about ankle ligaments, this is one place to look. So this is a website that the sort of maintained by the ISS and SSR. It's a good resource for sort of residents or even attendings if you're looking at any kind of specific pathology you want to look at. This is one of the things that I work on. So if you have any suggestions, please feel free to go there, fill out the survey, and see if or any suggestions about any additional stuff you want to add to it. And so also here, if you want to know more about ankle ultrasound or just MRI ankle ligaments, these are 2 lectures on that, one from Drew Ross and Dr. Mansour. And also thanks to Dr. Owlett, who's actually helped me out with this as well. And that's it. However, I just want to say thank you. So thank you to the Bone Squad for inviting me. Really appreciate it. I mean, these lectures that I've seen so far from other people have been amazing. So very honored to be part of it. Also, thank you to Deanna Hammond. She's the stenographer who actually drew all the pictures. I can't draw very well, so I have to always give her a shout out. Also, it's the UCSF crew. There's the attendings we have at UCSF. Also, a special shout out to sort of mentors at UCSF, Dr. Thomas Link and Dr. Lynn Steinbach. In addition to mentors I had at Henry Ford, where I did residency and fellowship, Dr. Vance Holsbeek and Dr. Craig, who've been very helpful, and they're the ones who sort of introduced me to ultrasound. And then also, that's it. That's all I have. There's just some images from where I live. In case you're interested, one on the bottom right is the World Dog Surfing Championships. It's in my town of Pacifica. So if you're interested in that, definitely come by. We're always looking for more people at UCSF. So if you're interested, fill out an application. All right, that's it.
Thank you so much, Kevin. That was a great review of the topic. Really interesting. So we will open it up for questions. Remember, you are being recorded. So if you don't want to be recorded, you can just put your question in the chat or ask away.
There's a comment from Mohammed. Wonderful lecture. Thank you so much. Another comment from Tanya. Great talk. Thank you. I was just in San.
So yeah, so do we routinely do 3D formatting? We don't do it routinely. I mean, I think it's something that we can do, but also I mean, you know, I'm sort of more of a strong believer in ultrasound. So ideally, I feel like we should be able to make the diagnosis on MRI like enough, like, because it's not just what the image is, it's going along with the physical exam findings, the history, the type of injury. Once you put all that together, MRI is going to be pretty good for the vast majority of the time. And when it's not, when there's concern about it, I prefer to have I prefer to have the ultrasound. I don't think we can. It's difficult to preemptively know which people would need that. We need the fancy MRI, and that's why I think it's sort of difficult to use it routinely.
Sounds good. I think we have comments or questions in the chat.
We will go to Mohammed first, who has his hand up.
Thank you.
Thank you very much. In the case of anterior talofibular ligament injury, do you also look for associated injury to the Bassett's ligament?
So in the case of sort of ATFL injury, I look for injury to the what ligament?
Bassett's ligament.
Not routinely. I mean, I guess I'm not sure if the surgeons like really sort of ask for that. So I think that's I guess, I mean, at least the surgeons we have not really asked. I mean, is that something that happens where you at your institution?
Yes, they ask.
Oh, yeah. That makes sense.
Yeah, thank you. I have just a second question, quick question. Could you explain if there is a relationship between the conflict with the peroneus tertius muscle and the calcaneus fibular ligament?
Can I explain if there's a what's the word?
With the calcaneus fibular ligament.
No, I mean, if there's the what between the peroneus tertius and the calcaneus ligament?
Yeah, peroneus tertius muscle and the calcaneus fibular ligament. If there is a relationship, in case of conflict, for example.
Oh, I mean, like, do we conflict is in, do you mistake one for the other on ultrasound?
Yeah, sometimes we have a relationship between a conflict, including the peroneus tertius muscle and calcaneus fibular ligament.
Yeah, I mean, I haven't had that issue before. I mean, I think because I mean, I think the key is once you get the if you can get so one thing that helps, I think, is to make sure sometimes it's helpful to use the smaller transducer, but also use the bigger one as well. Like because the small transducer is helpful to get in the little grooves of the foot, but then sometimes you need the bigger transducer so that you can actually see exactly where different things begin and end. And so I think as long as you're seeing that, especially with the dorsiflexion, I think we can. That's how I kind of avoid sort of confusing those two. So that's I use for MSK. I always use multiple transducers. That's another thing I'm not sure if I talked about yet. So I try not to just use one transducer whenever I'm evaluating.
Okay, thank you so much.
We'll go to a question from Dr. Pua. Hi, Dr. McGill. What is our threshold for grade 1 ATFL injuries? Sometimes it's as subtle as an intermediate signal only on T1.
Yeah, I mean, for that, I mean, I'd say I mean, I think if there's any kind of if there's any signal, I'll usually call some sort of injury if it's because I mean I think the normal the normal ligament shouldn't have much signal in it, as long as if a patient has had, especially see the patient's had an injury there or had some lateral ankle pain, and if it has high signal, then I'll say if we're talking about because if you're just talking about kind of grade 1 injuries, obviously for the grade for the higher grade injuries, we're looking for kind of more sort of abnormality within the ligament itself. But that's the thing that I also combine, make sure I talk to the surgeons and make sure look at the history. If there's no history, then I guess it's if there's no history of injury to that, and there's no pain, we have markers, no marker there, then they'll be a little different. As far we're just talking about sort of grade 1 injuries, then but usually if there's any signal, we'll call it grade 1 injury.
Next question is from Brian. Are your surgeons performing surgery based on ultrasound? For instance, they'll do lateral ankle surgery when you see ATFL tear on ultrasound. Maybe he's getting at the peroneus cordis and the CFL.
I would say so. It depends. I think that so are they in general, like, for it's not as far as is it standard? No, not at this point. However, they do perform, but if it's something they specifically ask me about, then yes. So if it's just if it's just a random patient who hurt their ankle and then they come to get ultrasound and then go see a surgeon, then they may or may not. But if it's a patient who's seen the surgeon, especially if they had an MRI and they had sometimes they've gone back and forth with, especially if they've had patients who they actually had a repair already, and the surgeon's like, well, can you check? There's, because there's a lot of like artifact on the MRI, and then then they are doing ultrasound. They are doing surgery based off of the ultrasound. Yes.
Next question is from Kenneth. Superb lecture. Thank you very much. Do you have any anatomical landmarks for the superior anterior talofibula ligament versus the inferior band?
Well, I mean, it's essentially the same, the same thing of the fibula, except you just start in the front and keep going down until you get to it. I don't have yeah. So I mean, I think that for that one, yeah, I just go anteriorly. Wait, make sure that you see the fibula, the anterior part of the fibula, and then go medially until you see the tibia, and then just keep scanning down until you run into the anterior tibial ligament, and so that's it.
We'll take the question from Dr. Pua. Go ahead.
Hi, sorry. Good morning. Sorry, it's morning here. I just have a follow-up question with regards to the ATFL sprain. Is it okay if we don't call it, if it's, as what I asked a while ago, if it's as subtle as an intermediate signal on T1? Like, is it okay if we don't call it, or will it impact a lot clinically?
Well, that's the thing. I don't think it impacts much clinically. So that's what So it's if we're only talking about sort of grade 1 injuries, because essentially what happens with the doctor's going to, or the surgeon's the question is, are they going to do physical therapy or surgery? So whether you call it, if you don't call it or call it a grade 1, they're still, in general, they're probably going to still do physical therapy regardless. Now once you get to grade 2 or 3, that the answer, things change. But if they have pain there, and especially if the physical exam has already kind of suggested that that's where their pain is